Hello, good day. We will be discussing in this lecture video about your immunoproliferative disorders. So, immunoproliferative disorders, they consist mostly of malignant transformation or malignancy among hematologic cells. But in this topic, you will be discussing mostly on lymphoid origins. So in immunoproliferative disorders or in malignant transformation of your hematologic or lymphoid cells, cell properties and genetic changes happen. So the malignancy that occurs reflect the result of initially normal processes in which the problems are the main regulatory steps in order to control the level of cell proliferation have failed. So it's either the maturation arrested into an early stage of the cell lineage, and then even though the maturation arrested, proliferation continued, and the regulation of our immune system or the hematologic components of our immune system rely heavily on regulatory controls. And if one of those controls or steps happen to be mutated or have failed to initiate regulation, there can be another step towards malignancy. So our cells of the immune system or the lymphoid cells or the lymphoid lineage are also susceptible to malignancy. So the classification of your hematologic malignancies are tackled, and a lot of schemes have been used over the years in classification these malignancies. So we refer to them as hematologic malignancies because your immunoproliferative disorders are mostly composed of problems with blood cells. So the French, American, British classification was used as a consensus criteria for leukemias and myelodysplastic syndromes. Now, the revised European American lymphoma classification was also used for leukemias and lymphomas. So this scheme is now the basis for classification of all types of hematologic malignancies and is currently being updated every now and then. So this is widely accepted and for now is considered the gold standard in classification of tumors for diagnosis and determination of appropriate therapy. So you can find these examples of the diseases under the classification of real classification in your book. So the hematologic malignancies under this classification is divided into 12 major groups and with different subgroups. So we have three major types of hematologic malignancies which we will tackle here. So yung leukemias, lymphomas, and plasma cell dyscrasias. So your leukemias are generally divided into two types or two groups depending on which they originated. So we can have the myelogenous types of leukemia or the lymphocytic types of leukemia. So the myelogenous type of Leukemias are derived from common myeloid precursor, and it includes granulocytic, the monocytic, megakaryocytic, and erythrocytic leukemia. Aside from either myeloid or lymphoid, we can also classify leukemia into acute or chronic types. So the chronic leukemias usually are in slow progression and has extended survival. While they are not generally curable with chemotherapy, they manifest longer survival compared to those with acute leukemias. So your acute leukemias are, some of them are curable, but if the chemotherapy is not initiated early on, there is a high mortality rate among patients with acute leukemias. So the acute lymphocytic leukemia is an example under the lymphoid series type of leukemia. So the general characteristics of this type of leukemia is that there are poorly differentiated precursor cells in the bone marrow and peripheral blood, so blast cells. And the age predilection of this type of leukemia is about 2 to 5 years old. We have 4 types of ALL depending on the dominant type of malignant cell and on the depending on the surface receptors found. So we have the CALA expressing precursor B cell ALL, pre-B cell ALL without CALA, T cell ALL, and the mature B cell ALL. So we use cytogenetic studies to provide information which is important in diagnosis and prognosis of patients with ALL. So in this one, the CALA expressing precursor BLL is the most common type of ALL, and the pre-B cell is the second most common type. So it's important to take note that in pre-B cell ALL without CALA, there is hyperdiploidy. So the malignant cells contain more than 46 chromosomes. But if that is noticeable, it presents better prognosis compared with those who have hypodiploidy, meaning lesser than number of 46 chromosomes in their malignant cells. So that hypodiploidy type of ALL provides poorer prognosis. So if we provide ALL, what is the most common na translocation found in ALLs of B cell origin? So the translocation 1221 and P13 long arm 22. So this is the most common translocation found in ALL of B cell in origin. Next is the chronic lymphocytic leukemia or lymphoma. So cell lineage in this CLL is almost exclusively of B cell origin, and age predilection is higher than ALL, which is 50 years and above. So the usual findings for CLL is there is increased lymphocyte count in the peripheral blood. So the anemia and thrombocytopenia are not present early on in the diagnosis. They occur if the disease is in later course or progression. Next is your hairy cell leukemia. So in hairy cell leukemia, there is infiltration of bone marrow and spleen, but there is no involvement of lymph nodes. So the age predilection of hairy cell leukemia is about 20 years old and above, and the initial hematologic presentation is bone marrow disease and pancytopenia. So we can notice also markers, mature B cell markers, CD19, 20, and 22, and also the IL-2 receptor and CD25. The IL-2 receptor, which is CD25. So the CD103 and CD123 are better B cell markers. So the CD103 is most sensitive and specific for hairy cell leukemia, while the CD123, though found on other types of leukemia, produce darker staining in the cells of positive with hairy cell leukemia. So the characteristic cells in hairy cell leukemia contain the acid phosphatase isoenzyme 5. So we can detect that histochemically, and it provides resistance to tartrate treatment. So one of the most accurate diagnoses for hairy cell leukemia is using cytomorphological or immunophenotypic characteristics. Now we go to lymphoma. So because of the different overlapping clinical behavior of lymphoma and leukemias or other neoplasm, the various lymphoma or the lymphoid neoplasms can only be distinguished properly with morphologic and molecular characteristics of the tumor cells. So when we prognosticate and diagnose lymphoma, it's important to focus or take note on the tumor cell identity and not on the area of location in the patient. So the B and T cell tumors are composed of cells that are arrested at a specific stage of their normal differentiation. So the diagnosis and classification of these tumors rely heavily on immunohistochemistry or flow cytometry because it detects lineage-specific antigens. For example, B cell, T cell, or NK cell markers. So the markers are identified by their cluster of differentiation number or CD number. That's why we test for the CD markers found on the malignant cells. So, ang mga most dominant or most common lymphomas are derived from germinal centers or post germinal centers na B cell. And remember that class switching and somatic hypermutation in the maturation are mistake-prone forms and can promote genomic instability. So, yung germinal centers of B cells are high risk for, yung germinal center B cells are high risk for potentially transforming mutations. So, take note that all lymphoid neoplasms are derived from a single transformed cell. So, the lymphomas are generally clonal, and it disrupts immune or normal immune function. So, it can promote immunodeficiency or autoimmunity. So, either of the two can happen among patients with lymphoma. So, the origin of lymphoid neoplasms are shown in this illustration. So, there are different stages of B and T cell differentiation in which the tumors or specific lymphoid neoplasms can emerge. So, pwedeng during sa pre-B lymphoblast stage, it will arrest in maturation and proliferate as the pre-B lymphoblast, or pwede rin na sa CD4, CD8, or sa mantle zone B cell or marginal zone B cell. So it can happen. So example of your lymphoma is Hodgkin's lymphoma and non-Hodgkin's lymphoma. So yung Hodgkin's lymphoma have two divisions, yung classic HL and yung nodular lymphocytic predominant HL. So the characteristic cell among patients with Hodgkin's lymphoma are the Reed-Sternberg cell or the RS cells. So they are large with bilobed nucleus, ito, and two prominent nucleoli. So this feature gives the owl's eyes appearance on Reed-Sternberg cells. So Hodgkin's cells are closely resembling RS cells, but the Hodgkin cells do not have bilobed nucleus and nucleoli. So there were additional subtypes noted in Hodgkin lymphoma. The following are the 5 subtypes of your Hodgkin's lymphoma. So, yung nodular sclerosis, mixed cellularity, lymphocyte-rich, lymphocyte depletion, and lymphocyte predominant. So, among these 5 classification, this classifies as classical HL, and this is the NHL, NP, LHL. So your Hodgkin's lymphomas, they arise in single lymph node or chain of lymph nodes, and they spread on contiguous or adjacent lymph nodes. For your non-Hodgkin's lymphoma, so it is composed of a wide range of neoplasms, and the most predominant type of lymphoma under this NHL are the B-cell lymphomas. So we have 3 characteristics that identify lymphomas as having B-cell origin. There should be presence of surface immunoglobulin. It can also contain CD19 and CD20, and there are rearranged immunoglobulin genes. Now, your plasma cell dyscrasias are also immunoproliferative disorders, and these conditions are characterized by overproduction of single immunoglobulin component. So, ang tawag natin doon are the myeloma protein or M protein or paraprotein. So, your M protein is associated with other lymphoproliferative disorders, not just plasma cell dyscrasias, but it is mostly evaluated under plasma cell dyscrasias because we detect and quantitate M protein. So, example of plasma cell dyscrasia is yung monoclonal gammopathy of undetermined significance. So, a patient with serum monoclonal protein concentration of less than 3 grams per dl, a plasma cell count of lower than 10% of the total cells in the bone marrow, and the absence of signs or symptoms associated with multiple myeloma, known as the CRAB features, yung increased serum calcium, renal failure, anemia, and lytic bone lesions. Now, yung multiple myeloma naman, or plasma cell myeloma, it is a malignancy of mature plasma cells. So, this type of plasma cell dyscrasia will have plasma cells that express CD38, CD56, and CD138. So, like most other B-cell malignancies, the myelomas often have chromosomal translocations. So, it usually involves the heavy chain of immunoglobulins and are located in chromosome 14. So, ano yung mga other genes involved? Pwedeng cyclin D1, pwede ring D3 or fibroblast growth factor receptor. So, the proliferation of your myeloma cells is actually supported by interleukin 6. So, the interleukin 6, diba, they are produced by fibroblasts in the bone marrow stroma. So, the proliferation of malignant myeloma cells are somehow supported by increasing IL-6 by the myeloma cells. For the next type of plasma cell dyscrasia, we have what we call Waldenstrom macroglobulinemia. So your patients with this type of plasma cell dyscrasia have elevated serum monoclonal protein. We refer to that as macroprotein or IgM paraprotein, and we can detect that during serum protein electrophoresis. So there is a malignant transformation of IgM producing lymphocytes. So the B cells or plasma cells that are present in this plasma cell dyscrasia produce the following markers: CD19, 20, 22, and 79A. But the markers CD3, 5, 10, and CD103 are not expressed. So all individuals with Waldenstrom macroglobulinemia have elevated monoclonal protein or IgM paraprotein, and sometimes in 10 to 20% of patients, these IgM paraproteins can behave as cryoglobulins, and it or it can agglutinate RBCs and also produce autoimmune hemolytic anemia. Other examples of diseases are your heavy chain diseases. So these are rare B-cell lymphomas that are characterized by overproduction of monoclonal immunoglobulin heavy chain. Among the heavy chain diseases, your alpha heavy chain disease is the most common of the three types. Your gamma chain disease naman is a rare disorder and is associated among patients with autoimmune disease like rheumatoid arthritis. And the mu heavy chain disease is also a rare disorder and is associated with patients with lymphoid malignancy, and it resembles CLL in terms of morphology. So, yung heavy chain diseases, these are not specific entity, but this represents the group of proliferations in which only the heavy chain is being overproduced. So, alpha chain heavy disease is the most common type among the heavy chain diseases. So this is an example of the characteristic surface markers found on the different hematopoietic malignancies. Now, how do we detect immunoproliferative disorders? So what is the laboratory perspective in diagnosis? So we have three major types of tests we use to diagnose: immunophenotyping, serum protein electrophoresis, and immunofixation. So the immunophenotyping uses flow cytometry in understanding the population of cells. So flow cytometry, so this is ideal for fluids like blood in which the cells are being suspended. And then this is an example of an illustration of flow cytometry. So the blood will be sipped here, and then because of a funnel-like structure, the cells will be able to line in single line and will pass through the different light source, and we will read the forward light scatter and the side light scatter in flow cytometry procedure. So what we check using flow cytometry procedure is the size, granularity, the surface and intracellular antigens found. So this is an example of how the cells are being analyzed through flow cytometry. So the cells will receive light, and the amount of light scattered usually represent the size of the cell, while the side light scatter usually represents the shape and granularity of the cell. So there can be different presentations of lymphoid abnormal cells, and we can test that using flow cytometry. So these are the different commonly detected markers through through flow cytometry. So yung T cells, makikita natin ito ng mga markers, and B cells ito. So since there is no single surface marker that is specific for hematologic malignancy, so the laboratory uses a panel of antibodies to identify markers for proper diagnosis. So we also do evaluation of immunoglobulins. So your basic immunoglobulin unit, diba, it consists of two identical heavy chains and two identical light chains. So it is connected by disulfide bond. So, in testing presence of gammopathy, we can use serum protein electrophoresis, and the quantitative measurement of immunoglobulin levels in the serum is now routinely performed. So when the serum is subjected to electrophoresis, the serum proteins are separated based on their size and charge. So in this area, this one, so this is an illustration of a stained agarose matrix. So the intensity of the staining represents the amount of protein in each region of the gel. Immunofixation electrophoresis, on the other hand, involves two major steps. So step 1, proteins are applied into the agarose gel and are separated according to their surface charge. And in step 2, the specific anti-sera are added to each one of the lanes, and they will react with their corresponding protein to produce a precipitin band. And from there, we detect what type of immunoglobulin is predominant. We also have what we call immunotyping or immunosubtraction. So this is a variation of immunofixation. It uses capillary electrophoresis in identifying monoclonal immunoglobulin components. And aside from immunotyping or immunofixation of antibodies or cell surface markers, we also have evaluation of chromosomal or genetic abnormalities. So among the different types of immunoproliferative disorders, most of them have a characteristic cytogenetic evidence. So for example, si chronic myelogenous leukemia, there is noted na translocation between chromosome 9 and 22. So these translocation can be detected by cytogenetic techniques, and the malignant lymphoid cells are made to proliferate in vitro, and they are examined based on their metaphase chromosome. So traditional cytogenetic evaluation using karyotyping can also be used to supplement the new technique, which is the FISH or the fluorescent in situ hybridization. So this is how it looks like. So the fluorescence in situ hybridization can demonstrate chromosomal translocation. So in this illustration, you will see that the cells being examined are interface cells, and they are being hybridized by molecular probes. So here, in green signal, it represents the breakpoint cluster region or BCR on chromosome 22. Yung red signal, it represents the ABL1 in chromosome 9. And yung yellow signal, it represents the BCR-ABL1 fusion caused by chromosomal rearrangement. So this is normal. This is abnormal with the BCR-ABL1 fusion. 1 fusion. 1 fusion. So this is how useful FISH is in evaluating chromosomal abnormalities, especially in immunoproliferative disorders. So that's it for our immunoproliferative disorders. Most of the topics here in this discussion overlaps with hematology, and I hope you will read your book. This is a short chapter in Stevens. It shows different types of immunoproliferative disorders together with detection. So thank you and study well. God bless.